less crowding. The profile is flatter. To summarize, less crowding with flatter profiles. We've done our extractions, and how do we move the anterior teeth posteriorly? Generally, we move two cuspids back and then the four incisors. The reason being that there's less anchorage loss of the posterior teeth, that is, posterior teeth moving forward by retracting cuspids alone versus retracting six teeth, the cuspids and incisors at the same time. If that's what you want to do, of course, with the treatment plan. So following 4 first bicuspid extractions, you retract the canines first, then the incisors. Eventually will retain. Anchorage considerations. We can increase anchorage with full bracket engagement of the wire, which provides the stationary anchorage that we talked about previously, only allowing bodily movement for maximum resistance. We can reinforce anchorage with headgear. We can retract canines with elastics, with springs, in which case we're pulling cuspids back. We can put in springs and push cuspids back, an occlusal view of the pushing cuspids back scenario. When the canines are retracted, we hold everything back with steel ligature wire, then proceed with incisor retraction. In the complete arch wire technique, we band, bracket all teeth, progress through the arch wire sequence, and use closing loops or elastics to move incisors posteriorly. Retracting incisors tend to elongate, so we compensate with intrusion bends in the arch wire. In the Class 1 Type 2 cases, we're dealing with spacing. Again, we have a Class 1, but we have spacing present. You have to ask yourself, why is this spacing present? Look for habits. Want to manage that first. And we retract incisors as in Class 1 Type 1 cases. Type 3 cases, which was thoroughly covered by Dr. Falsafi. Anterior crossbites of one or more teeth. What we want to look for is spacing or room for in these cases, the upper centrals to move forward. Do that with removable appliances, fixed appliances. Example of a removable spring. Advancing one or two teeth, we can use a device called a lower inclined bite plate, but generally can't recommend using that, since if you get hit in the face with a soccer ball, for example, the tooth will contact the plate and possibly fracture. We can advance teeth with opening loops and arch wires, with springs. If we have an anterior crossbite, remember we're still in the Type 3, of 3 or 4 teeth, then we're looking at most likely skeletal discrepancy. Type 4 cases, we're talking about posterior crossbites, which again, Dr. Falsafi has covered. Note that if the midlines don't coincide, there's this unilateral crossbite from mandibular shift to that size. We can treat posterior crossbites with removable appliances, fixed appliances, combination appliances. Diagram and photo of a removable crossbite corrector, a fixed appliance with the Hyrax or Haas types, which we're turning the screw, causing a lateral expansion, opening the mid-palatal suture with the fixed RPE in the right age group, of course. So reviewing the class 1, type 3 of 1 or 2 upper incisors of an anterior crossbite, we can use appliances. 3 or 4 incisors, we're cautioning a skeletal discrepancy, which changes the whole treatment plan. It's a skeletal problem. The type 4, it's the crossbite. Type 5, what has happened is that there's loss of teeth with drifting, and we treat this similar to a class 1, type 1 patient.